Welcome to the module on shock and what is the definition of the shock, how to do classify the shock and investigations and management of a case of septic shock. Right. How to define the word shock? Shock is nothing but a systemic state of low tissue perfusion. Okay. What is shock? Shock is a systemic state of low tissue perfusion. Please remember the definition. Shock is a state of low tissue perfusion that is inadequate for normal cellular respiration. Normal cellular respiration. Okay. Shock is nothing but a state of low tissue perfusion that is inadequate for the normal cellular respiration. This is the definition of the shock. Now, how to classify the word shock? How to classify the shock? So, there are many classifications. One, we will look into the basic classification. Okay. Shock can be a hypovolemic shock. Shock can be cardiogenic shock. Shock can be obstructive shock, distributive shock, and the last but not the least is endocrine shock. Right. We have seen all the types of shock: hypovolemic shock, cardiogenic shock, obstructive shock, endocrine shock. These are all the very distributive shock. These are all the various types. Under distributive, there are three other types. I want you to write it down. 1. Septic shock. 2. Neurogenic shock. 3. Anaphylactic shock. Okay. Distributive shock consists of three main types: septic shock, neurogenic shock, and anaphylactic shock. These are also the parts of distributive shock only. This is how we are going to classify the shock. So not only classifying, let us look at the basic outline of each and every shock. We will just go through the basic outline. Okay. First one is hypovolemic shock. Hypovolemic shock. Under hypovolemic shock, hypovolemia, you already know the volume is less. Okay, the blood volume or the circulatory volume is going to be less. That is called as a hypovolemic shock. Decreased circulatory volume. This is your hypovolemic shock. Now I am going to divide hypovolemic shock into two. One is hemorrhagic and non-hemorrhagic. Hemorrhagic means what? The hypovolemia is due to hemorrhage. Non-hemorrhagic means it is not due to a hemorrhage. Now please divide it. One is hemorrhage. Due to, if a hypovolemic shock is due to hemorrhage, then I am going to call it as a hemorrhagic shock. Right. And the other is non-hemorrhagic. Right. Which is not due to a hemorrhage. Coming to the non-hemorrhagic one, there might be various causes to cause the hypovolemia. Now we will look into it. If at all the patient has dehydration, then the circulatory volume is going to be obviously reduced. Hypovolemic shock. Even in vomiting can cause hypovolemic shock. Diarrhea can cause hypovolemic shock. Urinary loss is there. If I take diabetes mellitus or diabetes insipidus also, in diabetes insipidus, what happens? There is excess urinary volume loss, which is leading to what? Hypovolemia. Now, and even in third space lossing, third space loss. Okay, can I tell you the example? I mean, if the fluid is lost into the GI tract, example in cases of intestinal obstruction is there, or in case of pancreatitis is there. In these cases, the fluid is getting into the gastrointestinal tract. So fluid is lost into the gastrointestinal tract. Okay, that is third space loss. We have seen the various entities which are causing non-hemorrhagic shock. Now coming to the next type of shock. The next type of shock is what? It is cardiogenic shock. Write it down. Cardiogenic shock. So why I am using the word cardiogenic? Cardiogenic means what? There is a problem in the heart. So let me draw a simple heart. So let us assume this is the heart and the four chambers of the heart. If at all there is a problem in the heart, what it is going to happen? The cardiac output which is coming from the heart is going to be reduced. If the cardiac output is low, what happens? What happens? The amount of blood reaching to the tissues is going to be reduced. So there will be low tissue perfusion state, which I am going to call it a shock. Now, coming to the cardiogenic shock, it is nothing but the primary failure of the heart. Primary failure of the heart to pump the blood. Okay. Now, can you tell me the various cardiac causes which can cause cardiac shock? Write it down. Myocardial infarction. Okay. And now, any arrhythmia, cardiac arrhythmias are there. Or you can take valvular heart disease is there. Or cardiomyopathies are there. These are all the conditions where the contraction of the heart is significantly impaired. When the contraction of the heart is significantly impaired, cardiac output is going to decrease. Decreased cardiac output will cause a low tissue perfusion state leading to a shock. That is why this is called as cardiogenic shock. Next, coming to, so where is the problem in cardiogenic shock? It is in the heart only. It is a cardiac entity. Next, coming to obstructive shock. So how to define this obstructive shock means there will be a decrease in the preload. What do you mean by the decrease in the preload? If suppose this is the heart attack, the amount of blood which is reaching the heart is going to be reduced, right? In simple terms, there is mechanical obstruction to cardiac filling. In simple terms, I can call this. Okay. Or maybe on this side, or maybe on this side, whatever it is, there is decrease in the preload. Okay, the amount of blood reaching the heart is reduced. So what are all the causes which can lead to this? Very important causes. Cardiac tamponade. Cardiac tamponade is one thing. Tension pneumothorax. Massive pulmonary embolism. Embolism and air embolism. So what are all the causes which are decreasing the preload? Cardiac tamponade, tension pneumothorax, massive pulmonary embolism and air embolism are the various causes which can lead to obstructive shock. Obstructive, why I am using the word obstructive? Why? Because there is mechanical obstruction to the filling of the heart. Okay, that is why I am calling it as an obstructive shock. Okay, now coming to the next type of shock, that is distributive shock. Coming to the distributive shock, I have already told you one entity is septic shock, which I will discuss in total now, and neurogenic shock, and the other is anaphylactic shock. These are the three main types of distributive shock. What happens in neurogenic shock is there will be failure of the sympathetic outflow. Very important. There is failure of the sympathetic outflow. You know, sympathetic system is the one which is going to regulate the blood pressure as well. When the sympathetic outflow is going to be reduced, what happens? The amount of blood flow to the organ is going to reduce, which is causing a low tissue perfusion state. That is your neurogenic shock. Now, what is anaphylactic shock? Anaphylactic shock occurs due to vasodilatation. But the question is, there is vasodilatation in anaphylactic shock, I accept. But what is the reason for vasodilatation? Because of histamine release. Because of histamine release, there will be vasodilatation, which is leading to anaphylactic shock. Now, septic shock we will come to in total. Now coming to the endocrine shock. In endocrine shock, what are all the endocrine problems which can lead to shock? In hypothyroidism, there is a risk of endocrine shock. I want to tell you there is a condition called as myxedema coma. If you remember, in hypothyroidism, it can also cause shock. Hyperthyroidism can also cause endocrine shock. One entity I want to tell here is there can be a possibility of high output cardiac failure. High output cardiac failure in case of hyperthyroidism. Next, adrenal insufficiency, again an important cause. Adrenal insufficiency. Let me tell you an example here. Addison's disease is an example of adrenal insufficiency. It can also lead to shock. Now coming to the feature. Now what we will do is, what is our main question is on about septic shock. Let us discuss the septic shock. Okay, now what is the pathophysiology of the septic shock, or pathogenesis or pathophysiology? Septic shock, you already know it is due to microorganisms. Septic shock, it is an infectious condition, microorganisms. So microorganism, or I can simply tell microbe derived substances will be there. What are those? PAMP. There are something you have already learned in pathology. PAMP, DAMP, pathogen associated molecular protein, PAMP. Right? Now, what are these PAMPs doing means, on one side what they are causing is activation of neutrophils, and they are causing activation of monocytes. Okay, activation of neutrophils and activation of monocytes. On one side it is causing endothelial activation. It can also cause the factor 12, and it is also capable of causing complement activation, which is C3 getting converted to C3A. Okay, now you already know factor 12 is a helps in coagulation. So it is a procoagulant. So due to this procoagulant nature, what happens is there is always a risk of microvascular thrombosis. Due to this coagulant nature of the factor 12, what happens is there is a coagulation leading to what? Thrombosis will be there. Microvascular thrombosis will be there. Ultimately, this thrombosis will lead to tissue ischemia. Okay. Not only there is increase in coagulants, but there is decrease in anticoagulants also. Due to complement activation and all those things, what happens is there is decrease in the anticoagulants. Like protein C levels are going to decrease, protein S levels decrease, antithrombin 3 levels are going to decrease. All these things occur. It can also lead to microvascular thrombosis. This complement activation, on the other hand, is also going to do endothelial activation. Right? Now, what happens to the neutrophils and monocytes? They are going to release certain inflammatory markers, very important for the exam. Interleukin 1 tumor necrosis factor alpha, interleukin 1 TNF alpha, never ever forget for the exam, very important, interleukin 1 and TNF alpha. Now these are the two things which are also activating what? Endothelium. So taking all these things into consideration, what happens is there will be release of interleukin 6, interleukin 8, nitrous oxide, something like a PAF, and some more like reactive oxygen species, and all those things are going to get released. So and what is going to happen with all these things? There will be very important statement, vasodilatation is going to happen, very important. Increased vascular permeability, very important. So with this there will be decreased perfusion. Ultimately these all things are going to lead to what? Multi-organ failure. Okay. Now what we are going to see here is there is microbe associated pathogens, right? Pathogen associated molecular proteins, PAMPs. On one side they are going to cause activation of neutrophils and monocytes. On one side they are causing endothelium activation and the complement activation and factor 12. Factor 12 is a procoagulant which is causing what? Microvascular thrombosis. Even complement activation will lead to decrease in the anticoagulants like protein C, protein S and antithrombin 3. It will also lead to microvascular thrombosis. Ultimately, this microvascular thrombosis lead to tissue ischemia. On the other hand, this complement activation can cause endothelial activation. Not only that, from the activated neutrophils and monocytes, interleukin 1 and TNF alpha are going to be released. These are going to act again where? On the endothelium only, endothelial activation. Ultimately there will be release of interleukin 6, interleukin 8, reactive oxygen species, PAF, nitric oxide, etc. What all these things are capable of causing means increase in the vascular permeability, vasodilatation, and decreased perfusion. Ultimately these all things will lead to tissue ischemia. Ultimately there will be multi-organ failure. This is how the pathogenesis of septic shock is going to be, right? So now coming to the what are all the features of a septic shock? Tell me the features of the septic shock. In septic shock, the systemic vascular resistance is going to be low. Please take a note. There is low systemic vascular resistance. Why there is low systemic vascular resistance? Because there is peripheral vasodilatation. Due to the vasodilatation in the peripheries, the systemic vascular resistance is going to be low. You already know any shock there will be generalized tissue hypoperfusion. This is actually the definition of shock only. Okay, I need not mention separately in septic shock. Now, in shock what happens is, any shock for that matter, there is low tissue hypoperfusion, so the aerobic metabolism is getting converted to anaerobic metabolism. When it converts to anaerobic metabolism, what happens? There will be lactic acidosis is there, right? Now, cellular dysfunction I am going to see. I have already told you, due to anaerobic metabolism, what happens? There will be lactic acidosis. We have already seen in the pathogenesis there can be multi-organ failure also can occur. Now, if I am looking at septic shock in early phases, what are all the clinical features I am going to see in the patient? I can see the evidence of volume depletion. I can see the evidence of volume depletion. What are all the things which can tell me the volume is depleted? Suppose there is a dryness over there, dryness of the mucosa. Dryness of the mucosa is there, then there is one. Cool, clammy skin, if I can see, then also it is a case of volume depletion. Now, I'm teaching you septic shock means there might be signs of possible infection I can see. So what might be the infectious signs I can see? First thing very important is fever. I can see something like a erythema. I can see localized erythema. I can see, or I can see tenderness. I can see maybe consolidation in the chest. Okay. If it is if there is a problem in the abdomen, I can see the tenderness. I can see the gourding. I can see the rigidity also. If it is a problem with the meninges, then I can see the signs of meningismus. Okay. Now, I can sometimes see the signs of end organ hypoperfusion. So what are all the signs of end organ hypoperfusion? Skin mottling of the skin is there, or sometimes I can see the digital ischemia. I can see, okay, in the kidney, if it affects the kidneys, I can see the oliguria also, okay, and maybe tachypnea can be seen, or I can see cyanosis. These are the various causes of various signs where I can see in a tissue hypoperfusion. Or if there is a or if it affects the brain, I can see the altered mental status. These are the various signs I can see. Now coming to how to treat a case of septic shock. My primary aim is to remove the septic foci. Removal of the septic foci is my primary aim. Okay. Now, how to do that? If at all there is a gangrenous bowel is there, I have to do resection, right? Resection of the gangrenous bowel. Resection of the gangrenous bowel I can do. Suppose there is a perforation which is leading to septic shock. What I have to do? I have to do closure of the perforation. Next, if the appendix is leading to septic shock, then what I have to do? Then I have to get an appendicectomy done. Okay. Now, not only that, I have to remove the septic foci. That's correct, and I have to give what? I have to start the patient on empirical antibiotics. Okay. Now even I have to provide some supportive care. I have to provide the patient oxygen. Even if needed, I have to do endotracheal intubation. And mechanical ventilation I have to provide. Okay. Now, what are all the other things I have to give in septic shock? IV fluids, any shock, IV fluids are part and parcel. Now, IV fluids may be crystalloids, maybe colloids, maybe I can use blood also. Okay, crystalloids means I can use a normal saline or I can use a ringer lactate. Colloids, what is the advantage of colloids is it is going to restore the intravascular volume faster, and it is going to maintain the intravascular volume longer also. But what is the major disadvantage with this? There is always a risk of pulmonary edema with the colloids. Okay, blood, if the patient is somewhat anemic, then I have to think in terms of blood. Crystalloids, colloids and blood if the patient is anemic. Crystalloids I can use normal saline or ringer lactate. Coming to the colloids, they are going to restore the intravascular volume faster, and they have the capacity to maintain it longer, but the risk of using colloids is pulmonary edema. Right, this is how we have to treat a case of septic shock. Right, even if the patient is already in a shock, and what are all the other things I can give? I have to give vasoactive agents, very important. I have to start the patient on noradrenaline, or I can give something like dopamine, or I can give dobutamine. But out of all these things, the most important is NORAD. NORAD is something which is capable of causing vasoconstriction. So, and it is going to increase what? Systemic vascular resistance also. When I am going to keep the patient on vasoactive agents, I should always monitor the blood pressure of the patient and the central venous pressure of the patient also. This is all about shock you have to know.